Hi, good evening. My name is Beth,
My name is Melvin, and I'm Rodger.
and together we're going to discuss borderline personality disorder. I'm going to talk about the definition and the history of borderline personality disorder.
And I will discuss the statistics and the diagnostic criteria based on the DSM-5.
I will then talk about the treatment, signs and symptoms, and therapy.
And then we will all conclude with the summary conclusion together.
All right. Borderline personality disorder is characterized by hypersensitivity to rejection and resulting instability of interpersonal relationships, self-image, affect, and behavior. Borderline personality disorder causes significant impairment and distress and is associated with multiple medical and psychiatric comorbidities. In the 1930s, Adolf Stern used the term borderline to describe a disorder that did not fit well into either the neurosis or psychosis category. Symptoms included hypersensitivity, difficulties in reality testing, and negative reactions in therapy. Knight, in 1953, used the term borderline to describe a group of patients with impaired ego functions and primary process thinking, which reflected unconscious wishes and urges. Others have described such patients as suffering from pseudoneurotic schizophrenia. Brinker, Werbel, and Dry in 1968 conducted the first empirical study of borderline personality syndrome. In 1980, borderline personality disorder was included in the DSM-3, and the ICD-10 uses the term emotionally unstable disorder.
Okay, again, I will be following Beth, my colleague, and I'll be discussing now the statistics following on with the diagnostic criteria. First of all, the prevalence of borderline personality disorder is framed in the United States. So these statistics is based upon the studies that was based upon the United States. In the United States, recent research has shown that 1.6 of the population has borderline personality disorder. That number may seem small, but when you consider how large the United States is, you may realize that 1.6% represents quite a large number of people. The gender differences. Women are far more likely to be diagnosed with BPD than men. In fact, 75% of people diagnosed with BPD are women. That ratios of 3 women to men to 1 man diagnosed with BPD, is that corrected? Misdiagnoses. While 1.6% is the recorded percentage of people with BPD, the actual prevalence may be even higher. Suicidalities, in reference to borderline personality disorder, includes some of the most sobering borderline personality disorder statistics come from research literature on BPD and suicidality. About 70% of people with BPD will make at least one suicide attempt in their lifetime. In addition, between 8 and 10% of people with BPD will complete suicide. This rate is more than 50 times the rate of suicide in the general population. In other words, those who suffer from borderline personality disorder has a higher statistical rate than just the average person who suffers from suicide tendencies. Okay? Furthermore, several diagnostic instruments are available to aid in diagnoses. This includes the McLean screening instruments for borderline personality disorder, personality diagnostic questionnaire, structured clinical interview for the DSM-5 personality disorder, the Minnesota Borderline Personality Disorder Scale, and the Personality Assessment Inventory Borderline Features Scale. Diagnostic tools may be separated into general categories of self-report and structured interviews. Patients with borderline personality disorder have been shown to have high rates of comorbid disorders, such as mood disorders, which has a 80% to 96%, 88% of anxiety disorders, substance abuse disorder ranging 64%, eating disorders are at 53%, bipolar disorder is at 15%, and somatoform disorders is at 10%. Lastly, attention deficit hyperactivity disorder, ADHD, ranges between 10% and 30%. The prognosis for BPD is a serious mental illness. It is by no means, though, a life sentence. Research has shown that the prognosis for BPD is actually not as bad as once thought. Almost half of people who are diagnosed with BPD will not meet the criteria for diagnoses just 2 years later. 10 years later, 88% of people who were once diagnosed with BPD no longer meet the criteria for diagnoses. Further on the prognosis, there is hope. There is a hopeful prognosis for patients with borderline personality disorder. A longitudinal study of 290 inpatient diagnosed with borderline personality disorder and had recessed at 2-year intervals over 16 years, yielding the following rates of remission. 35% remission after 2 years, 91% remission was after 10 years, and 99% after 16 years. So this is, again, not the end of the road. There is hope. A pervasive pattern, the diagnostic criteria, I will now be followed by my friend and colleague, Mr. Rodger.
Thank you, Melvin.
Yes, sir.
So I'll be going over the diagnostic criteria, signs and symptoms, and treatment. A pervasive pattern of instability of interpersonal relationships, self-image, and affects, as well as marked impulsivity beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of the following. 1, frantic efforts to avoid real or imagined abandonment. Note, do not include suicidal or self-mutilating behavior covered in criteria. 2, a pattern of unstable and intense impersonal relationships categorized by alternating between extremes of idealization and devaluation. 3, identity disturbance, markedly and presentedly unstable self-image or sense of self. 4, impulsivity in at least 2 areas that are potentially self-damaging. For example, spending, sex, substance abuse, reckless driving, binge eating. Note, do not include suicidal or self-mutilating behavior covered in criteria. 5, affective instability due to marked reactivity of mood, for example, intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours and or rarely more than a few days. Chronic feelings of emptiness, inappropriate, intense anger, or difficulty controlling anger. For example, frequent displays of temper, constant anger, recurrent physical fights. 8, transient stress-related paranoid ideation or severe dissociative symptoms. Signs and symptoms. There are 4 main clinical theories in borderline personality disorder, BPD, with distinct core pathological mechanisms. 1, Kernberg's 1967 theory assumes that BPD is characterized by excessive aggression, which is genetically determined or due to excessive frustration in childhood. Lenin's 1993 biosocial model of BPD hypothesizes as the core feature of the disorder pervasive difficulties with emotion regulating. 3, starting from the attachment perspective, Bateman and Fongi, 2004, conceptualized BPD as a failure in mentalization, reflecting the inability to identify mental states in oneself or in other to recognize how these mental states are mutually influenced. 4. Ultimately, Gunnarsson and Lyons-Ruth, 2008, developed the interpersonal hypersensitive theory of BPD that postulates a genetic predisposition to hypersensitivity and hyperactivity to impersonal cues. Treatment of borderline personality disorder relies on psychotherapy. 3 evidence-based therapies are effective for patients with borderline personality disorder. First, mentalizing-based therapy, MBT, helps patients manage emotion dysregulation by feeling understood, allowing them to be more curious and make fewer assumptions about the intentions of the people around them. A secondary therapy, dialectic behavior therapy, better known as DBT, combines mindfulness practices with concrete interpersonal and emotional regulation skills. Third, transference-focused psychotherapy, TFP, focuses on using the patient's therapist relationship to develop the patient's awareness of problematic interpersonal dynamics. MBT and DBT each incorporate individual and group treatment over 12 to 18 months. For adolescents, family therapy may be an appropriate substitute for group therapy, though this is not always the case. Borderline personality disorder is one of the most difficult mental health disorders to manage. It is best managed with interprofessional team, including psychiatrists, psychologists, a pharmacist, mental health nurse, and social workers. Pharmacists review prescribed medications, check for drug-drug interactions, and provide patients education. Mental health nurses and social workers provide care, monitor patients, participate in education of patients and their families, and provide follow-up with the team. Fortunately, there are no medications that seem to help. Psychotherapy may help some patients, but compliance with treatment is low. The outcomes for most patients are poor, with many running into legal, social, and even personal problems.
Summary conclusion. Why choose borderline personality disorder? Well, as part of the DSM-5, we recognize that borderline personality disorder is one of those conditions that many of our populace suffer from. So those of us in the helping career professional field, such as social worker, clergy, and or counselors, we recognize that this condition we may face in helping people cope with normal life. So the reason why we chose this subject, because it's prevalent. It's most significant today. As we discussed with the statistics and the criteria, there are many who suffer from borderline personality disorder. And those of us who have a passion for people, we want to help those people as well. And as we saw with the remission rates, 2 years after diagnosis, they can go into recess. 10 years could yield a 91%, and 16 years can yield 99%. So we want to help those people overcome whatever challenges they face, especially those that is induced upon by borderline personality disorder. That is why we chose it, because we have a passion for people, and we recognize that we may, in our professional career, face people or clinically, tongue-tied again. We recognize the fact that in our future profession as clinicians, we will face borderline personality disorder. And in that, we have chosen this mental health condition so that we can help people overcome those challenges and be prepared.
All right. We wanted to talk a little bit about the integration of scripture or Christian faith as it's relevant to borderline personality disorder. There was a study by Hosak in 2019 that found while religious engagement, such as attending church, reading the Bible, or prayer, was low for those with BPD, religious quest, which refers to the internal openness to faith and spirituality for those with BPD was high. It could be that their difficulty in keeping interpersonal relationships could keep them from engaging in church activities. However, their inner turmoil could cause them to pursue a higher power and the meaning of life.
The next is how could someone from, say, the community or the clergy or social workers benefit from this information? Simply put, this information can help just to identify simply that the interpersonal relationships, battles and struggles that the person struggling or client struggling with borderline personality disorder can overcome, as we saw, as Brother Melvin pointed out. A person who is diagnosed with BPD could find extreme difficulty participating in community events, just as I said previously. However, with the help of social support systems stemming from the community, professionals could help them be more sociable and engaged, therefore having a better outcome and look for the future.
Excellent. Well, that concludes our presentation. At this time, these are the references that we've derived information from. As you see, we got Caviccioli and Maffey. We got Chapman, Jamil, and Fleischer. We derive information as well from Craighead, LW, and Milkowitz, DJ, and Craighead, WE of 2013 relevant data, and then Hozak 2019. Last but not least, we got Pinnell 2020, Borderline Personality Statistics from the Very Well Mind website. If there are any questions, feel free to email us or join the link down there, and you can reach us at Colorado Christian University. Thank you for listening. Thank you for your time. Beth, thank you for your participation and commitment. Rodger, thank you as well. And thank you all again for joining us, and we look forward to maybe engaging y'all in the future on a different subject of mental health conditioning, as we are now studying in the clinical mental health field. Have a great day, and God bless.
And that's that.